Dr. Critchman, I so enjoyed your talk, and one of the things I wanted to comment on was I was very impressed with the fact that you put the decreased sexual desire screener, the DS, in your waiting room, because I think that must create such an open atmosphere with your patients, inviting them to talk to you about these issues.
Well, Marianne, I appreciate the feedback, and I think it's really important. You never get a second chance to make a first impression. Mm-hmm. And I think it's really important to create a comfortable environment for patients to know that this is a safe place for people to talk about sexual health concerns. And I think it's very important to discuss issues with your front office staff when they're answering the phone. And you brought up the point in terms of this therapeutic alliance, in terms of discussing the issues and how patients, what I would call, have the concept of serial disclosure. They want to develop a relationship. It's very intimate details that they may have never discussed ever before. And I think it's really important to create that comfortable environment, not only in your waiting room, but also to encourage patients that what they say is confidential, and that no one will access their chart. Because I think this concept of disclosing a very intimate part of you is one of the issues that we see as clinicians that make people very vulnerable. And they're very apprehensive because they're wondering who's going to see this, how this information may be used, who may have access to it. So confidentiality certainly is very important, and the openness to discuss it also very important. I mean, the DSDS has been validated in a variety of forms. I know other clinical practices that put it online. You could print it out. If a woman is apprehensive to talk about it, she can just fill it out and give it to the nurse, and that will have a springboard effect in terms of creating a comfortable environment. But one point I wanted to really discuss with you was the concern of the impact. And I think you brought it home very well in your presentation in terms of affairs and distress and even the concept of depression. And I think as healthcare providers, sometimes as medical clinicians, we tend to kind of minimize the impact and minimize and say, these drugs, they only may increase one satisfying sexual event, or they may not have much of an impact. But I think it's really important that we change that dialogue. We need patients to be able to talk about it, and we need clinicians to have the opportunity to speak with it again.
I so agree with you, and what might sound to one not a frequent sex life or not a satisfying sex life, like for example having intercourse once a month, to a couple that is struggling, once a month is huge and can keep a relationship strong and satisfying. So it's important for practitioners not to put their own judgment calls on people's experience, but to find out, to ask them, how is that for you, and not make an assumption about how much sex people need to be satisfied, for example.
Right, and you brought up the point about the 7-minute visit, and I think one issue that I wanted to bring forward is that clinicians tend to interrupt their patients within the first minute of them speaking. And medical clinicians tend to do the machine gun effect. Do you have this? Do you have that? Do you have this? Do you have that? How about this? Not this, then that. And they don't really allow the patient to speak. And I think that creates a very apprehensive environment. So one of the keys, I think, is to recognize, and the studies support the fact that if you talk about sex and you give the patient the opportunity to speak, it's not going to bottleneck your office, and you'll be able to get the questions answered. And I think it's okay to let the patient know that sexual health is a very important part of their overall general health, and that we may not have ample time to talk about this in this visit, but we want to schedule the right amount of time to discuss this issue and address it. And I think you bring forward a very important concept about the assumptions. And as clinicians, as medical doctors, we make assumptions about our patients, oh, she's old, she may not be interested in sex, or, she doesn't have a partner, she may not be, or she's only involved in a heterosexual relationship. I think it's very important to look at yourself as a clinician, especially a medical clinician, and really address those shortcomings before we walk in the door, because we always are being examined by our patients.
Very true. I think it benefits the physician as much as the patient when they create a comfortable atmosphere for their patient, because if their patient feels like they can talk about sex, it's going to increase their confidence in their practitioner just generally and develop their comfort level in that office in a general way, which is enhance that relationship and keep that patient happy.
Right. And I wanted to also reiterate the misperception about clinicians and sex therapists. And as you know, I'm a gynecologist. I'm also a counselor. I collaborate very closely with sex therapists. You and I have collaborated many times in the past, and I know we'll collaborate more in the future. And I think there's this very big misunderstanding about what sex therapy is. And I'm wondering if you could just talk a little bit about sex therapy. And I'm finding that I'm always telling patients that sex therapy is not sex coaching. It's not sex surrogacy. It is what the facts are, because I think clinicians, as doctors and nurse practitioners, sometimes we don't know what goes on in these sessions. And again, patients also feel like there's this misunderstanding and misrepresentation. And I certainly ascribe to the concept that we work better together than against each other. And I really encourage the dual effect. I know you do too, and we complement each other. But I think there's a lot of misunderstandings in terms of what sex therapy or sex counseling really is. So if you could touch upon that, I think that would be a great help for both the clinicians and patients as well.
Absolutely. And, you made a point in your presentation that just because you see a therapist, it doesn't mean that your relationship is in jeopardy. And I agree with that so much. It doesn't mean that someone is functional or ill, but it does, seeing a therapist or a sex therapist can really support a couple in highlighting their assets and working through where their challenges are. So it doesn't mean that someone is dysfunctional or the relationship is dysfunctional. Sex therapy is very much like general therapy, except that the focus is on intimacy and sexuality. Now, that will vary depending on where the couple's particular concerns lie. So sometimes sex therapy really just is about communication and general communication. Sometimes sex therapy is about cultivating time together and learning to be kind to your partner, how to give and receive love. Sometimes it is much more specific to sex and discussion of how people initiate sex, what sort of foreplay they have, how they can cultivate a more intense or exciting atmosphere during sex. But it's ultimately, sex therapy is a lot like general therapy, just with the focus on sexuality.
Right. I mean, I think that's very important. And, in California we have sex coaching and sex surrogacy, and I think there's a lot of confusion. But, in terms of cognitive behavioral counseling, we very often give exercises, we give activities, we have a lot of homework and handouts, and really try to change thoughts that may be negative or counter-sexual or what have you by different kinds of behavior. I wanted to ask you a quick question, and I have a little comment. I know that you recommend 50 Shades of Grey, as I do, but I also think that we need to set realistic expectations. I think sometimes we need to know who our patients are, and I think we need to screen those, because I've had some women who've read 50 Shades of Grey and have had a negative experience. So again, although I certainly agree with that, I think it's very, very important to kind of know your patient, individualize. And I always say I have a very large war chest with a lot of different ammunition to counteract. And some women will come in and say, I want everything. I want a moisturizer and a lubricant and a vibrator and a book and a video, and I want some medicine, and I want testosterone, and I want this and that. And other women will tiptoe gently into the treatment realm. And just the intervention just the discussion, just the validation is huge for them. So I think the concept of what you're mentioning is individualized is huge, and it's quite essential to understand that.
I agree with you. I often say to my patients that when I encourage them to explore erotica, I'll say that there might be one line or one phrase that strikes you in that erotica and the rest of it just not interesting to you. And that's pretty typical. Women can be very particular about what is exciting for them. So I do encourage women to not expect that they're going to just, everything they read is going to be exciting to them or anything that they do should work.
Right. I think that's very important to individualize. And you mentioned something about bad coping skills, and I think as clinicians we have bad coping skills in terms of dealing with some of the pressure and anxiety from insurance and reimbursement. But you mentioned things like food and sedentary. And I also want to throw in the concept of this digital addiction, the chronic checking your phone, the email, the iPhone, the iPad, the iWatch. This digital age has not really improved our sex life. If anything, it acts as an impedance. I see couples that are texting each other and they're in the same room. So I think getting down to the basics in terms of communication are vital. And as healthcare providers, we need to employ and use good communication skills to create a comfortable environment for our patients. So, I think those are very important take-home points for the listener as well.
Absolutely.
I had one more comment, and I wanted to kind of talk about this, the concept of helping rather than healing. And I think that's one of the bridges that we need to learn as healthcare providers. I think healthcare providers have stayed away from talking about sex because we sometimes feel hopeless and helpless. We want to cure. We want to change. We want to rectify the issue. We want to give a medicine and make all the symptoms go away. And we don't like when things are gray. We like things that are black and white and that we can implement effectively and know A goes to B, goes to C, goes to D. And I think that comment about helping versus healing is really, really remarkable and very important. I'm wondering if you could just touch upon that as well and see what do you think the differences were.
Well, one thing that comes to mind is when we imply to a patient that this will work, or it should work for you. It can be very shaming for a patient when they don't respond initially to whatever the intervention is. So it's a much more compassionate approach to give people space to find their way and set, as you said, a realistic expectation about this being a process, and that she may even be revisiting issues from her past that she thought she had already resolved. And she may find that she gets to a certain point and then things shift again for her in her lifetime. So it's an organic, ongoing experience, our connection to our sexuality. Bodies are always changing, relationships change. So rather than thinking of putting it in a certain sort of category and fixing it, it is a very kind way to approach the topic with a patient to create an expectation of a journey. This is a journey, and it's a creative journey that we'll explore together and see where it takes us.
Right. And again, different people will have a different experience, and I think that we have to kind of break the silence on both ends. So clinicians need to actively ask. We need to create a comfortable environment. And I think there's a very big disconnect. I think clinicians go into the visit and say, if sex or sexual health issues or pain or desire was a problem, then my patient would bring it up. Mm-hmm. And patients, on the other hand, say, if it was an important concept in my overall general health and well-being, then my clinician would bring it up. So again, this conspiracy of silence, we're not talking about it, we're not engaging, and even little things, as you mentioned, like having a screener in your waiting room is very, very helpful to break the silence and really create those things. So, patients notice everything So they'll look at these materials maybe the first time and think that's interesting, or take something and put it in their pocketbook and then review it at home. And again, I think asking, we know that the data supports that our yield will be so much greater if we as clinicians ask the right questions and allow the patient the opportunity to speak. It'll be much better in terms of overall discussion and yield in terms of what we can do and impact our patients.
Yes, and what a comfortable atmosphere for your patients to be able to walk into your office and see that they can bring issues up, and anything is fair game. So that's really going to just cultivate their sense of comfort with you and with their experience of medical care in general.
Right. And I think that we each have our own way of creating a comfortable environment. In mine, we start with a phone call. We reassure about confidentiality. We give questionnaires. My office may be a little bit different than the average clinician because I'm a tertiary referral and I see people who are, really coming in for that. But again, I think allowing the patient the opportunity to speak is a very, very critical facet without interruption, and validating, actively listening, as you said, make eye contact, nod, reassure the patient, and allow them the opportunity to speak in a comfortable setting is quite essential to break down that anxiety and that concern.
Mm-hmm. That's really true, and allowing a little bit of silence for the patient to gather her thoughts and speak.
Yeah, we get really uncomfortable when things get quiet. I think as clinicians we're just not used to it, and it makes us really uncomfortable, and we feel like we have to fill the dead air. I think those are very, very important. One thing you mentioned when we were talking and during your slides is you talked about this desire discrepancy, and I think that I reframe it in a different way a little bit. I talk about acceptance and compromise. And in my house, you empty out the dishwasher even if you don't want to. And I think that reframing desire sometimes is very, very important. For many years, clinicians in the medical field had thought that women's desire is exactly like men's, and that it may always be spontaneous, and it always was biological. We know that men and women are hardwired differently, their brains respond differently, the hormones are different. Sometimes reframing desire is very important, and this constant concept of really understanding that to make a marriage and relationship work, we are compromising constantly. It's whether we compromise on what we do, the activities, where we go for dinner, where we vacation, how we spend our money. Relationships are give and take. They're selfish. They're selfless. Sex may also fall into this realm as well. So having a good understanding of that is quite essential.
That is a great point, that compromise exists in all aspects of a relationship, so why wouldn't it be also applicable to a sexual relationship? Very true.
Yeah, and we're getting bombarded by all these things in the media, that the stars always have to be aligned, and it always has to be perfect, and and it always has to be mutually orgasmic and wonderful and amazing. That's not always the case. We're getting all these messages from external sources, whether it's magazines or television or the media, understanding that sexuality is an individualized experience based upon the relationship and your own personal beliefs and what have you, I think is really, really essential.
I absolutely agree. And, I tell couples that it does require time and some effort to continue to maintain a satisfying sexual relationship. It just doesn't happen for couples. Those that are satisfied in a longer-term relationship, they do continue to put effort and energy into their intimate relationship in general. So it's important to keep that in mind. If this is a priority for a couple, then they do need to allocate time and just energy for it.
Right, and I think, we get lulled into thinking that, our relationship should be on autopilot.
Yeah.
And it's automatic, and that's what happens. We get into the rut, and I call ruts routine, unimaginative, and tiresome. And we get into rut, and then it becomes Saturday night special between 11 and 11:30, whether we want to or not. It takes work. It takes effort. And for me in my clinical practice, the things that I see are the couples that do well sexually as they age, and in spite of the fact that they may have chronic medical disease or on medications, are the couples that value the importance of it and value the importance of the connection, both physical and intimate, and they're working towards it. So relationships take a lot of work, and it's not to be set on autopilot. I think that it's very important to reassure patients that you need to work at relationships to work, and sometimes we forget what we really need to do.
Absolutely true. I very much agree with you.